The Jagrati, have you called Dr. Minu?
Yes, she has called.
Okay, okay.
You can do audio and video testing till then.
Sorry?
You both can start with audio and video testing till that time.
Okay, okay. One second, I'll just.
Yeah, video is clear.
Voice is also clear?
Yes, yes,
Okay.
clear. Is there any disturbance from my side
No,
in audio?
no, no, no. It's fine.
Oh, thank you. Good evening, sir. Hello, sir. Good evening. Sir, kindly make me host. Thank you, sir, for making me host.
हेलो।
Good evening, ma'am.
हाँ, गुड
Ma'am,
इवनिंग।
yeah, ma'am, speaker ma'am is just joining in 1-2 minutes.
ओके, नो प्रॉब्लम।
Yeah.
आपने इसमें ग्रुप में डाल दिया है?
हाँ हाँ डाला है मैम, वापस एक बार डालती हूँ मैं।
ओके, सो टुडेज हु मींस हु इज कंडक्टिंग? डॉक्टर आरती एंड डॉक्टर जागृति?
Yeah, Dr. Aarti is going to do the introduction and Dr. Jagruti will take Q&A.
ओके। हेलो डॉक्टर आरती, डॉक्टर
Yes, good
जागृति।
evening, madam. Good evening, madam.
गुड इवनिंग। नाइस टू सी यू बोथ ऑफ यू अगेन।
Thank you.
Good evening, everyone. Our speaker is going to join us shortly, and then immediately we are going to start.
Hello, good evening, ma'am. The speaker is joining within 5 minutes.
Yes, Jia.
Have you checked the means any kind of problem is there or network issues or something? Okay, Prajakta. Jagruti, Dr. Jagruti.
I think madam has joined.
Yes, I have joined. Yes.
Yeah. So can we start?
Yes.
Okay.
Madam has joined.
Can you just share?
Yes.
Yeah.
Good evening, madam.
Good evening, ma'am.
Nice to see you again, and we are very much.
Thank you, ma'am. I'm sorry.
for
I
this
got a little
webinar.
bit late. I'm very sorry.
No. It's fine, ma'am. It's fine. We are eager to hear you.
Thank you, ma'am.
Okay. Now we can start, Dr. Aarti.
Yeah, sure. Am I audible?
Yes.
Yes, ma'am.
Yes.
Okay. So, very good evening to all of you. On behalf of NIMA Central and NIMA OBGY Central, I welcome you all for the 46th lecture of Blockbuster Master Webinar Series organized by NIMA OBGY Central. Today's topic is A to Z Ethical Aspects in ART by Dr. Meenu Bhanot. Myself, Dr. Aarti Kulkarni, and I'm coordinating this webinar with Dr. Jagruti Patil. So it's my great pleasure to welcome all the dignitaries of NIMA Central. Now I welcome the dignitaries of NIMA OBGY Central, Dr. Kamini Dhiman ma'am, Dr. Priyanka Nakade ma'am, Dr. Vishnu Bhavne sir, and Dr. Rajesh Utani sir. I also welcome dignitaries of NIMA OBGY Maharashtra. Proceeding further, we are now virtually going to inaugurate this webinar with Dhanvantari Stavan. So join your hands, close your eyes for Dhanvantari Stavan. नमामि धन्वन्तरिमादिदेवं सुरासुरैवन्दितपादपद्मं लोके जरारुभयमृत्युनाशनं दातारमीशं विविधौषधीनाम्. Now I welcome today's speaker, Dr. Meenu Bhanot. She has done Masters in Biotechnology of Embryology and Human Reproduction from University of Valencia, Spain. She is a research scholar in biotechnology, LPU, India. She is senior embryologist, lab director, and co-owner of Advanced Fertility Services and IVF Center in Jalandhar. She is also lab director of Star Fertility Jalandhar. She has also worked with Nova Jalandhar, SPS Hospitals Ludhiana. She is life member of NIMA, IFS, ISAR, IMS, ACE, and MACE. Her area of interest is recurrent implantation failure. So let's welcome the eminent speaker, our today's speaker, Dr. Meenu Bhanot. Please start your presentation, ma'am.
Yes. Good evening. My presentation is my laptop, but I'm joining through my phone. So you have to start my presentation through like. Hello?
Yes, ma'am. Yes, yes.
Yes, Dr. Jagruti, just go forward.
Yes, ma'am.
Yes.
Ma'am, I couldn't share my screen.
The screen will be shared only by the host.
Yes, ma'am. I'm the co-host. I
No,
request
no.
Dr.
Aarti
Aarti.
has to share it or
Yes.
make Madam host.
Hello, Dr. Aarti.
Dr. Aarti need to share it.
Yes, yes, yes. Okay, so okay.
Until that Dr. Jagruti keep muted everyone
Yes,
during the
ma'am.
lecture. Yes.
Yes.
चार्जिंग पे बोले कोई फोन ना चार्ज खत्म हो गया।
Just 1 second, I'm sharing.
Yes, it's
Yeah.
visible.
Yes.
So,
Dr. Aarti, just check whether it's
Slides are moving or
sliding or
not?
Yeah, slide share.
Yeah.
yeah, it is.
Yes.
Yes.
Okay.
Thank you, Dr. Aarti.
Yeah, yeah.
First of all, I would. Should I start? Am I audible?
Yes, ma'am. Yes, you can.
Good evening, everybody, and sorry for being late for the meeting. And just thank you. I just want to thank NIMA OBGY Society for giving me this platform to share my views on this. So after very colorful and joyful festival of Holi, and that is, I would say that the festival of unethical issues also. Sometimes we being very happy when we do some mischievous things on Holi. But my topic is A to G of infertility treatment, the art. So my next slide, ma'am. My topic is A to G of ethics for infertility treatment, the art. Next slide, please. The flow of presentation would be like it is the ethics we have to follow to the recruitment of the patient before planning the treatment and during the treatment. So I will be discussing all the ethics during recruitment, during planning of the treatment, and during the treatment. So it all starts with history taking. Next slide, ma'am. It's all start history taking. Whenever the patient with all the files and with the husband, with everything, when the patient came to the OPD, what is we have to do? Next slide, ma'am. Recruitment of the patient. Infertility is the disease of the male and the female reproductive system defined by the failure to achieve the pregnancy after 12 months or more of regular unprotected sexual intercourse. And infertility affects millions of people and has an impact on their families and communities. An estimate suggests that approximately 1 in every 6 people of reproductive age worldwide experience infertility in their lifetime. Next slide, ma'am. The word cloud determinants of woman reproductive age. Like when a woman is infertile, suppose she is suffering from subfertility or infertility, the lot of questions she has to hear from the relatives and the family, and we came to know that my income is low, I don't have any house, my education is less, my husband is not educated, I have to think about the genetical everything, and this is just the word cloud of determinants for women reproductive age. Next slide, ma'am. So I divide the reproductive age of women is like of 3 types, like early reproductive age when it is less than 25, mid reproductive age when it is 25 to 35, and when it is late reproductive means above 35. When it is less reproductive age, the estimate is that around 30% of the women are in this area when they come to the doctor for their fertility treatment. Mid reproductive age is 20% of the women would come to the doctor, and more than 50% of the people would come in the late reproductive age for their infertility treatment. Next slide. So, when the patient is with early reproductive age, next slide, ma'am. When the patient is in early reproductive age, the patient can wait. So the doctor have to decide that yes, wait can be done and proper evaluation should be done for this patient, because this is less than 25 years old. She has few years to work for. When the patient came in the age of reproductive age, we can plan and we may wait. But when the patient is in its late reproductive age, we have to act immediately. Next slide, ma'am. Type of infertility, we all are aware of. It is of 2 types, primary and secondary. But here, one more thing we have to think about, that whether the infertility is explainable or unexplained infertility. When the infertility is explained, that we know that this is the problem, this is the problem, this is explainable. But when there is no problem and you have to evaluate what is the problem, then it is called unexplained infertility, and ethics come into that type. Next slide. First, we have to evaluate male and female infertility evaluation on very first visit. We have to take history, the prior paternity for the male, prior paternity, cryptorchidism, medical and surgical history we have to know, sexual dysfunction, use of medication, tobacco, alcohol, any drugs the male is taking, physical examination for the testicular abnormalities like varicocele or absence of vas deferens. We have to evaluate everything. And in case of female, we have to find out whether she is having any prior maternity. Suppose in sometimes she is having second marriage, and what was the status of her previous marriage, what is the ovarian reserve, ovulation assessment we have to do, assessment of the uterus and fallopian tubes, lifestyles, abuses, physical examination to find out whether any abnormality per vagina and PS. So if we find anything like this, then we can explain. If still we don't find any problem, everything is normal, then what to do next? That is unexplained infertility. So we have everything with us, and now we have to see that the rate of, ma'am, next slide, please. Rate of natural conception decrease with failed trial of conception each number of times. Suppose the couple is trying to get pregnant, but they are not getting the conception. Then the every trial after every month, the rate of conception is decreasing. Young couple in the age of 23 to 37 trying to conceive for the first time, pregnancy rate per month is 30% in first 2 months, declines to 8% after 6 months, and further decline to 4% after 9 to 12 months. Next slide, please. So this is the doctor when the treating physician, he has to decide when, how, and what. Next slide, ma'am. These are the general factors like age, ovarian results, oocyte quality, endometriosis, uterine factor, cervical mucus factor, tubal dysfunction, immunological factors, genetical factors, coital difficulties, male factors, failed fertilization. There could be anything which can tell us that this was the cause of infertility and even the failed IVF. But these factors are not necessarily excluded in majority of the published study of unexplained infertility. When you have done IVF, then only you come to know that there is a failed fertilization. When you check like semen analysis, then you will see that, oh, it's a male factor, or the patient is having some tubal dysfunction or anything. But how many tests we should ask the patient to undergo so that we can find out the cause of infertility. Next slide, ma'am. So these are the explainable causes. So this could be maternal, paternal, and embryonic factors. Like if the maternal factor, we have to see anatomical factor, like if salpingectomy has been done, or myomectomy has been done, or polypectomy, and we can treat every explainable cause. Like, and if an anatomic factor is there, we can treat it. If there is impaired endometrial function, we also treat it with using aspirin. There are so many drugs like GCSF and everything we can treat. Thrombophilic, we can use aspirin or low molecular weight heparin. Immunological factor, we have to IVIG. But when the causes are unexplainable. So next slide, ma'am. This is the most when the patient come and you know you cannot treat this.
Hello, Dr. Meenu, ma'am.
I think she got disconnected.
Yes, ma'am. I will call her just a second.
Yeah.
Dr. Prajakta?
Yes, ma'am. Ma'am is just joining.
Okay,
Our
okay.
speaker, ma'am.
Okay. Whether she got disconnected?
Yeah, she got disconnected.
Okay.
She will join in 1 minute.
Ma'am, kindly unmute yourself.
Hello? Hello?
Yes, ma'am.
Yes, ma'am.
Yes.
Yes, ma'am.
I'm sorry. It was some problem with the connection, I guess. So, am I audible and should I start?
Yes, ma'am.
Yes,
Please.
ma'am.
Yes, ma'am.
Yes. So, the main problem is with unexplained infertility. We have to find out that the patient is regularly mensurating. We have to take the menstrual history. 3D scan is very important. If you don't have 3D, then 2D is even okay. Normal uterine cavity you have seen. Then you have to see whether the tubes are patent or not. Stereosalpingography, patent fallopian tubes, we have to see. And the better way to see the fallopian tube is through HSD. And when we have to, the preference should be oil over water based contrast medium, and sometimes you have to see the x-ray also, that whether the report has been given normal or not. Otherwise the radiologist will say that the spill is there, the tubes are patent, but sometimes the spill is not there, it is not working properly. So the semen analysis we have to see according to WHO criteria whether the semen analysis is normal or not. Then how to manage these cases? We have to consider the prognostic factor, whether the good prognosis, poor prognosis, or we have to go for IVF. The good prognosis is the expectant management for 6 months. And during this expected management, we have to plan for the patient, and we should tell on first visit that yes, if we feel that your prognosis is good, and let me try for 3 to 6 months. If you don't get pregnant within these 6 months, then we will think of some other plants. Next slide, ma'am. Hello. Yes. Empirical treatment. For next 3 to 6 months, which empirical treatment we need to give? We have to consider the efficacy of the treatment. It's not that we just give a little bit of medicine or something like that. Okay, you take this multivitamin. We should treat. We have to consider that whether the single drug I am writing is efficient for that patient or not. Otherwise, it will add on to the cost for that patient. Sometimes I have seen that you take this medicine, you take this medicine till then. It should not be done. We should, if empirical treatment we have to give, we have to consider the efficacy of the treatment also. We have to think of the cost. It should not be too much on the pocket of the patient. Progression of the treatment initiated with the least invasive test. We have to go for least invasive test, which should be least expensive, and the gradual progression to assisted reproduction therapies if initial treatments fail. It is not that on the first visit we should say that go for ART. Some recent practices, however, have advocated moving more quickly to ARTs. Next slide, ma'am. This is the slide which should show to every patient, I guess, that there are some patients who would come on the second or third year of their life, and they would then again say that yes, we want to see it with medicine, if you can help it out. Then this chart should be shown to them that after 24 months, if the patient who is having 40% of chances in their first month, after 24 months the chances of this getting pregnancy will be over. There will be no chance. And those patients who are having 1% of chance, but they are going continuously staying together, there could be 21% of the chances that these patients may conceive in these 2 years of their relationship cohabiting together. So we have to tell the patient that your chances are like this, you should wait or you should not wait. Suppose a patient has come who is ageospermia, they can wait for so many years, then the patient, the wife will never conceive. So it is the doctor who has to guide them for how long they should wait. If they have this graph, I show to every patient that this is your chances if you have not conceived till now. So let me start the treatment the way I want to do that. Next slide, ma'am. This is a very fine study, and you will see that they have studied the number of subjects over they have studied that clinical pregnancy rate with gonadotropin and IUI has been increased with gradual increase. When there is when you give only IUIs with gonadotropins, the rates are less, but when you do IVF, the rates per cycle get increased. Next slide, ma'am. So now we are clear that we have to give expectant management. This is the guidelines given by ASRM. So expectant treatment may be provided to the couple who are comes in the category of good prognosis. Next slide, ma'am. This is I will come to this later on. Just next slide, please. So here we can next slide, ma'am. This is the semen analysis. The WHO edition, 6th edition has been now out, and we should calculate the report on this basis only. Sometimes the patient would say that I want to wait for 5 to 6 months, 5 to 6 days before coming for semen analysis. This is not at all the requirement. If the count is, the patient has has discharged the semen sample just 6 even hours before, then only the volume will be low, but the per ejaculation, per million count, per ejaculation will never get. You have to calculate it, and you have to find out that what is the forward progression, what is this you have to find out on the basis of WHO criteria only. And see here, this very important thing, when we will see a normal report, then they will say the normal normal forms are 50%, 60%. This is not at all possible. We have to check it on like slide, but nowadays there are very computerized systems where we need not to calculate and no need to make any slides, and this is very useful. This is AI based computer application which will tell you, and every clinician can have it in their clinics and the hospitals to find out the normal semen analysis. Next slide, ma'am. So let us discuss about the guidelines. So ovarian stimulation with oral agents only. What the doctors will do, they will not go for any ultrasonography, what they want to do, but it is recommended that couples with unexplained infertility should not be prescribed clomiphene citrate alone, as it provides no advantage over expectant management. Aromatase inhibitors like letrozole, they are even not of any benefit in comparison to benefit in clomiphene citrate. Somebody say that we are not using clomiphene citrate, we are using letrozole these days. Even I would say that there is no use of even using this letrozole above clomiphene citrate. It is not appropriate to provide natural cycle IUI in unexplained infertility, since it provides no advantage over expected management. Suppose the patient has come mid-cycle and you see the egg and everything you find, you cannot ask for that, okay, I will do IUI. It has been seen that there is no use of using this IUI in natural cycle. You should abandon this. Ovarian stimulation, the available data is insufficient to support the use of only gonadotrophins in the treatment of unexplained infertility. So we have to see for aromatase inhibitor or the clomiphene citrate, then add on with gonadotrophins, then there are results, but alone gonadotrophins are not going to help. IUI with oral agents is an appropriate treatment in couples with unexplained infertility and more effective than expectant management. When you see that the tubes are patent, the semen analysis is normal, then you should do IUI first to start with ovarian stimulation, and then you can give gonadotrophins, and then IUI should be done. It should not be done that patient has come and just let's do it this cycle only. This is just a wastage of the money. Oral agents can be utilized for IUI with either letrozole or clomiphene citrate. Ovarian stimulation with gonadotrophins and IUI. It is not, ma'am, next slide, please. Yes. For couples, last one, ma'am. Last one, ma'am. No, ma'am. The previous one. Yes, this one. For couples experiencing unexplained infertility, gonadotrophin and IUI may be recommended. Next slide, ma'am. Yes. Patient should be informed that IUI with gonadotrophin is linked to higher rate of single. If you have considered that you will do IUI, you should inform and take consent from the patient that a single pregnancy or multiple pregnancies may happen per cycle compared to IUI with oral medicine. It should be written. Patient should know that the patient can suffer with multiple pregnancies, suppose 3 or 4 eggs, then triplets and quadruplets may happen, especially in case of unexplained infertility. Next slide, ma'am. Sometimes I have seen the doctors would suggest that I will do diagnostic laparoscopy. Laparoscopy is not recommended in unexplained infertility until or unless there is any tubal or any pelvic disease. Yes, if you want to see for any sort of pelvic tuberculosis or any sort of adhesions and you see that the tubes are blocked, then you can guide the patient to go for laparoscopy, but not for diagnostic laparoscopy is not recommended now these days. Next slide, ma'am. In vitro fertilization, IVF can be offered as an effective first-line treatment in unexplained infertility when the patient has come into in the later age. Couples with unexplained infertility should consider IVF after 3 unsuccessful rounds of ovarian stimulation or IUI. So we should we should tell the patient that after 3 IUIs, we will definitely go for IVF. But in the meantime, you will come to know that how the follicles are maturing, how the linings the patient is making, and maybe in these 3 to 6 cycles, the patient may conceive. Next slide, please. And further, this is one thing that is recommended over there, that if we say that some doctors exploit that we do only ICSI and all that. Now, sometimes uh, it is not above the evidences say that the use of ICSI during IVF may lower the incidence of complete fertilization failure, but there is not enough data to support its routine use in couples with unexplained infertility in an attempt to increase the live birth rate. The meaning is that it is not necessarily that you do ICSI, but if only IVF is done, then you may not face after ICSI the complete fertilization failure. IVF can result into the complete fertilization failure next day. ICSI is just to help to fertilize the eggs. Complete fertilization could be seen in ICSI but not in IVF, but live birth rate is not guaranteed with ICSI. Next slide, ma'am. So during treatment, there is now the law is in place. The surrogacy law 2022 is in place. The couple, they have said that only Indian married couple you can take it. No, no lesbian, no gays, no single male is allowed to go for even IVF. The couples who are, if not not live in India, they have OCI card, they can only go for this IVF, and age should be less than 50 of male and 55 of sorry, a female age should be less than 50 and male age should be less than 55. Then only they can go for IVF treatment. And the clinics has been like IUI clinic level 1. If you have registered level 2, then you can go for IVF and ICSI, gametes and genetics handling and surrogacy. You can go for the ART banks to keep the data for male and female donors. They have to keep the donor data. They have to keep their identities, and they can send the investigated and stimulated donors, and the donor can give the egg only once in a time. Ultimate goal of all this discussion is carry home baby, the happiness, and good sleep at night, no lies, no worry. This is my main motive, that the patient should go home with carrying a baby. Happiness should be with the patient and with me too. I should have a good sleep at night. Don't lie to the patient. Whatever you find, you just tell the patient, so that there should be no worries that what you have said earlier, what is now, I have to tell. I usually tell the prognosis on the first visit that this is your prognosis, and this way we have to work, and me and my patient should go side by side, and we should also know that what is going to happen in the next minute. Next slide, ma'am. So the carry home message is the Surrogacy Regulation Act 2021 in place, and we shall all abide by laws. Semen analysis can be repeated if there is any abnormality in analysis. Sperm DNA fragmentation should not be as a routine test. Diagnostic laparoscopy, hysteroscopy should not be included in routine investigations. Otherwise, endometrial biopsy can be included to rule out endometritis and anovulation. Chromosomal studies of couples should not be in patients who are proven otherwise, like recurrent implantation, recurrent pregnancy losses and inherited trait, etc. If that is there, then you can ask the patient for the microarrays and NGS, not the routine. Like if you have seen that the semen analysis is fine and you can see that the lady is mensurating, then there is no need of going for chromosomal analysis. Yes, for find out the recurrent pregnancy losses and implantation failure causes, you should go for the high-end tests like NGS and microarray, and should be offered instead of routine tests. So this is, thanks for giving me your valuable time, and thank you, Dr. Kulkarni and Dr. she is Priyanka, and everybody. I just want to say thank you. This is, if any question, I am ready to answer.
So,
Thank you so much, ma'am, for such a wonderful lecture in a simple language and the simple explanations. The major points of infertility that has to be means very much getting means everyone should attempt during their routine practice. You have explained it very nicely, and I would like to thank you for giving your valuable time for us.
Thank you, ma'am. If there is any question, then we can discuss.
yes. Yes. I request all the participants, if you have any query or any question, please put your question in the chat box or unmute yourself. Ma'am, the first question is, as you have said that in unexplained infertility, the IUI should not be with natural cycle. So,
Yes.
what is the advantage of ovulation stimulation and IUI in unexpected infertility?
Suppose I would say that the patient has come to the doctor and patient is already making relation. You have make it clear that there is no coital dysfunction. The patient is ovulating normally. Then what else the doctor would do? They can have meeting at home. So IUI will not. This is the recommendation by ASRM and ASHRI that in unexplained infertility IUI doesn't help. There is very bleak chances and almost nil chances to give the patient pregnancy in natural cycle IUI. So this will increase the cost of the treatment. This is the only thing.
Okay. Thank you so much, ma'am. The next question is from Dr. Umesh Lunawat. Elaborate the endometrial biopsy protocol for anovulation.
Yeah. Actually, in my center, what I do in anovulation, it is like before when you the expected last menstrual period, when you're expecting the period, just before that menstrual period, you can do without any ultrasonography. You can find out that whether the endometrium is secretory or it is like progesterone it has done or not, whether it is secretory or anovulatory. You can find it out. But in our cases, when we do IVF for endometrial biopsy, we choose the luteal phase, the ovulation time. When you have seen the ultrasonography that the patient has ovulated, then you see, and we also check the progesterone level in blood and also the progesterone level in endometrium, so that we could relate it that whether this patient is getting good progesterone for the embryo transfer or not. There are two protocols. One you can do before menstruation, and second you can do after in the luteal phase after the ovulation. This will give you the idea. That depends upon how you want to practice this. There are two ways to do it.
Ma'am, if we are going for the premenstrual biopsy, then should we advise abstinence during this cycle or not?
Ma'am,
Because
you can see, but for the biopsy, you are not like they are the very small biopsy cannula, and I have seen that the patients if they get pregnant, suppose the patient is coming, if she is not getting pregnant for 2 years and 3 years, that's why she is coming to you. If you will take biopsy just before menstruation, this will not you are not clear. But abstinence is like, if you will say abstinence, the patient will go that the doctor is saying me to abstinence. So there is, I feel that we were doing it before when we started IVF. No, we were doing it, but I have seen that no patient has conceived in that period, and even the biopsy is coming that this is non-ovulatory cycle.
Okay. Thank you so much, ma'am. The next question is from Dr. Smita. What drugs you recommend on OPD basis for ovulation induction treatment?
So we give letrozole and clomiphene citrate also, but clomiphene citrate very less. But letrozole is my drug of choice. This is, I would call it it's a wonderful drug. Even I use for my IVF patients this letrozole. Letrozole helps in endometriosis also. In like if you have myometrial cyst also, And when you have stimulated the patient and its estrogen is very high, then even you can lower with letrozole. Letrozole is a classical drug, and I combine it with gonadotropin, and then I do IUI.
Okay, thank you so much, ma'am. The next question is, how many cycles do you stimulate consecutively?
Only three cycles, not more than that.
Yes, yes. The next question is, does blastocyst hatching necessary in every case? If yes,
No.
how much time it increases the efficacy?
No. This is the recent study that the laser hatching to a blastocyst, which is of good quality, like A or B grade, then laser hatching doesn't help. The only laser hatching will help only in those patients who are high age, and you see that the zona is very thick, and that happens most of the time in the ladies we do IVF after 35. Then we see that it's already ready, ICM is there, and the trifactodome is very nice. Then we give a little bit short of laser and it will start hatching. Otherwise, laser hatching in a bad blastocyst will not help in achieving the pregnancy. And this is the recent report over there.
Okay, thank you so much, ma'am. The next question is, kindly describe the norms about surrogacy at current time.
Yeah. The surrogacy is it is initially when the law came in 2021, they said that the surrogate should be among the family. They should be related to you. But now they have asked that there is no need of the surrogate should be in relation to you. But yes, the surrogacy should not be commercial. The lady you are taking as a surrogate should be only altruistic. There should be no exchange of the money. And there are three, four forms which the intended couple has to fill. The intended couple should go to the gynecologist. This is the step one. When they say that the gynecologist will say that this is their problem and they are for sure have to go for surrogacy. Like there is absent uterus, the Mullerian, any Mullerian drug doctor this abnormality is there, that they have to go for surrogacy. They cannot carry. The doctor should be pro patient, not pro surrogate. One. Then with this form, the attending couple will go to appropriate authority. Appropriate authority will check they will do their counseling, that why they have come. They will look for their psychological condition. If they find that yes, both of them are fit to have a baby, then they will ask, okay, go and find out your surrogate. Then again that couple will find out the surrogate through either bank or someone. But the one thing is clear, that the gynecology should be out of it, and the surrogacy should be only altruistic. Suppose they have brought a surrogate, the gynecologist will say that yes, this lady is able to carry the baby. But one thing gynecologist has to see, that lady has never done a surrogacy before. This is a first time surrogate, and naturally the doctor will calculate about the risk of that patient. There should not be no risk. Like 23 to 35 year of age, the female can be the surrogate, but only one time in the lifetime. Then the doctor will give the certificate that she is fit to carry the baby. Then that intended couple and surrogate will again go to the appropriate authority, and then they will go to the magistrate, and then the paper will be in then only the treatment of the surrogate will be started for IVF. And when the baby will born, then only the High Court will deliver the certificate in the name of intended couple. So this is law. But initially when it was said that the couple cannot go for donor eggs or donor sperms for surrogacy, but now they have made it mandatory. They have done certain corrections that the intended couple can go for donor eggs also. A single woman, if it is a divorcee, and a woman divorcee and a widow can go for surrogacy, but she should have her own eggs. So these are the basic key facts when we do the surrogacy. We have to see that.
Thank you so much, ma'am. The next question is, what is PICSI?
Pixies like it is done for very small sperms. But ICSI is wonderful thing. PIXI need a different instrument attachment with your, and this is not done for human beings. This is done for animals like mouse. This is only in the experimental stage. Not PIXI is done.
Okay. Thank you so much, ma'am. The next question is from Dr. Ashlesha. What can be done in this particular case? That is, sperm count 1 million, motility is 10%, and progressive motility is 1%. Also, 99% morphological defect. Please
Oh
guide.
my God. This patient is 100% for ICSI
So,
and IMSI preferable. Yes.
yes. Thank you so much, ma'am. The next question is 10 million sperm count good for IUI or not?
Yeah, it is. It can actually. It should be 15 million. But what we do in some patient, when in young patient, what we do, we ask the patient to give the semen sample twice, um, like in not like half an hour or 1 hour. The patient can give the twice sample. We just collaborate these two samples and then prepare the sample for IUI. And what is the minimum requirement that 5 million sperm should go inside uterus in one IUI preparation. So this should be our thought process, that we have to send in 5 million 5 million sperms in one single sitting of IUI.
Okay.
So if you
Thank
can
you
do
so much,
that, then
ma'am.
it is fine.
Okay. Okay. The next question is, if all parameters of semen analysis are normal, only volume is 1.1 ml, is it need to worry, or it is because due to of collection error?
Yeah, mostly it is collection error, and sometimes the patient may have done masturbation then only, but you have to repeat it after 3 months. That if it is the same, then it could be there could be some problem in the glands.
Okay. The next question is, what are the points to be considered during IUI donor, or what are the ethical issues about the IUI donor?
No, by this law, they have the norms are very simple. The patient can bring their own donor. Simple viral markers, HIV, Australian antigen, and this HCV and BDRL should be normal. The genetic test like thalassemia only required, and the only the only thing is that the bank should be able to, the donor should be registered in the bank and he should donate only once. But yes, if the patient wants that, he wants the IUI from the same donor 3-4 times, they may go, but one donor can donate only once for only one patient, one couple. That's it.
Okay. Okay. Yes. Thank you, ma'am. The next question is gonadotropin with letrozole. Please explain the protocol.
Yes. In my practice, what I do, I give the, suppose the patient is with PCOD. What I do, I start letrozole one daily for 10 days. I call the patient after 9th or 10th day. When I see that there is a recruitment of the follicle, then if I feel that the follicle is little bit like 14-15 mm or 16-17 mm, it take one more day. If the patient can afford, I will ask the patient to give HMG 150 today, and then I will call the patient one day after. Most of the time the follicle is ready, but sometime after 10 days there is no recruitment of the follicle. I just give the letrozole another 5 days. The protocol is like 1 today, 2 next day, 3 next day, 4 next day. 10 letrozoles are completed in next 4 days. And most of the time when the patient comes on 15th or 16th day, I see that the follicle is almost ready, and if fine, there is little bit of discrepancy, or like I want it to be little bit more than what I would give, then I will go to gonadotropin HMG 75 or 150. Then we will call the patient next day. If it is ready, we will give the trigger, and after 36 to 40 hours, either natural insemination time or natural intercourse, or we will ask them to come for IUI. This is only my protocol. 10 to 20 letrozole will do my work most of the
Okay.
times.
Okay. Okay. Thank you so much, ma'am. The next question is sperm count 150 million, motility 48%, but normal forms 3%. What can be done?
Yeah. This patient can go for IUI. There is no problem in that. 3%
Okay.
normal is no problem at all.
Okay. Okay. Now, the next question is in unexplained infertility, complaining of dysmenorrhea. So, will this symptom is sufficient to advise her laparoscopy in view of endometriosis or not? Only dysmenorrhea.
Yeah,
And,
no, the recommendations say you should not be only dysmenorrhea should not be the criteria for the patient to go for laparoscopy. Must be they are thinking of that there may be some grade 1 endometriosis and something like that, but this is not the criteria. But if the patient is of high age, it should be directly go for IVF. There is no need to do for laparoscopy if there is you don't find anything like any hematoma is there or something like that. You should not be doing laparoscopy.
yes. The next question is at what level of AMH we should not wait or should go for IVF directly?
We keep the cutoff at 1. If the patient has come, the patient in the age of 26, 27 has come with AMH 1.0 to 1.4, then we would say that this is the best chance for you to take the baby home instead of waiting for more 6 to 7 months, and just we will give you ovulated drug and you will lose your more eggs. It's better to go for IVF. And I have seen the results. Young patient, 1 blastocyst, that works.
Okay. Thank you so much, ma'am. The next question is, can we still get anomalies in fetus even after blastocyst transfer pregnancies?
Yeah, anomalies could be there. Yes, anomalies could be there.
Which abnormality sperm morphology plays role in infertility, means head or of neck or of tail?
Yeah. Actually, the globulojuicepermia, this is a problem when even you do ICSI with this globulojuicepermia, you have missed in morphology. Like when the semen analysis, globulojuicepermia, these globulojuice these will never activate the oocyte. Even if you do ICSI with these globulojuicepermia, you will find the zero fertilization the next day. They cannot activate the oocyte. For this, you have to use some drugs during ICSI media to activate your oocyte. This is the only thing. But otherwise, if we have very bad samples when for ICSI, sometimes there are only 2-3 sperms. We start doing ICSI, and during ICSI, because of the bad morphology, the tail and head may get separated. I would say that the neck plays no role, but head and tail may get separated when we cut with ICSI. Then we have to put head first and then tail also, because tail will activate that oocyte. The head will give the genetical material to the oocyte. Then we have getting the pregnancy. But only globulojuicepermia, there is no fertilization, no pregnancy at all.
Okay. Thank you so much, ma'am. The next question is in PCOD letrozole, how much mg for 10 days?
Like 2.5 mg I would give for 10 days. And then again for next 5 days, again 2.5 mg, like I can give it.
Okay.
Okay.
Yes.
I just wanted to ask one question, if you allow me. Hello? Hello?
Yes, Dr. Yes.
Hello, I'm Dr. Sharyu Wankade. First of all, I wanted to congratulate you, Dr. Binu Banot, for your wonderful presentation.
Thank you. Thank you.
I just wanted to know that as it is practiced in EV Valencia, oocyte accumulation treatment, means they used to freeze oocytes in the first cycle
Yes.
or second cycle, 2-3 mature oocytes, and then we used to accumulate that and then fertilize in the third or fourth cycle and prepare blastocyst, and then we can transfer.
No,
So do you?
ma'am. Okay. this practice is not good. If you know that you want the baby from this partner, it's better to instead, like we used to do this, like in high age patient, when the patient is stimulated and only we could get only one egg, and that could form blastocyst, we will freeze. The next cycle we
No,
will
you are talking about embryo, ma'am. I'm talking
yes.
about oocyte.
Yes, that's why I'm telling you. If you know the partner that this is the sperm you want to use for your oocytes, then there is no fun, because the oocyte retrieval after thawing is very less. There is only 70% chances of if suppose you have oocyte frozen semen, you will get only 2-3 oocytes normal. But if the
Yeah,
embryos
that
are frozen, you will get 100% retrieval.
yes, but for fertilization, we need at least 6 mature oocytes. Then only we can go for the fertilization if we want to achieve a good blastocyst for the transfer day 5 or day 6. Say, so for getting a 6 mature oocyte in a say advanced age patient or lower responders, then in Valencia we used to accumulate oocyte, mature oocyte, M2 phase oocytes, and then we used to fertilize for embryos. So, do you practice the same or how?
No, ma'am. We don't do that, because
Okay,
in
okay,
vitro
okay. So
maturation
you
of the oocyte is also not good.
that is different. In vitro maturation is different. Then
Yeah.
you aspirate M1 and let it mature for the rest of the
Yes.
complete
Yes.
maturation period. But that is another that we
Yes.
cannot do in India. That is for the sure. But
Yes.
accumulation
Yes.
of oocyte is also different. And accumulation of the embryos, yes, that we can afford in India. So,
Ma'am, we do oocyte freezing in the cases who are diagnosed with
cancer,
cancer. Yes, we have
cancer,
done
yeah.
lot. We have done a lot of oocyte freezing, but we tell
Okay.
the patient that the retrieval is very less. You may not be getting out of 7, you may be getting 2 or 3. But today is a good day. I got a baby delivered, a male baby delivered through the oocyte freezing of a woman. She was to go for endometriosis surgery, and
Mhm.
before that she came to us. We have frozen her 4 oocytes, and after the surgery, when she came back, those 4 oocytes were thawed, and we get one blastocyst only. And today, that baby has delivered today. But
Oh, good.
unfortunately, what happened? There was some implantation of the endometrioma over there on uterus. There was infiltration of the endometrioma on the urinary bladder, and the surgeon,
Uh-huh.
when he was doing the surgery, he opened up the bladder also. That's why the whole hodgepodge has happened. And we waited for 3 hours when everything was okay. Then, but today we delivered a male baby with the frozen oocytes of that patient.
Okay, okay. So somehow it is practicing in India that you can freeze the
Yeah, yeah,
oocyte
ma'am.
also, and then you can,
Yes, ma'am.
yeah.
Yes, ma'am. We are
Mhm.
doing. Yes, we are doing.
Okay, okay, okay. And the second question is, do you follow ERA?
Ma'am, ERA is now outdated. Now, ERA, there is evidence, but we have started doing. We are doing endometrial biopsy for endometritis, TNF alpha. This is called a step test. We check cyclin E, progesterone, and THN, TH1, TH2, and this adhesive molecules, which are mucin. We just check that, but that we do at the time of after ovulation for embryo transfer. Endometritis, we also check. We check in this luteal phase, all these tests, but not ERA. ERA just tell you,
Okay.
ma'am, that what is the progesterone when you should transfer the embryo in the frozen embryo cycle. They will ask you that it is plus P+1, P6+7. That is
Yes, yes. Actually, I am also not for ERA.
yeah.
Means I don't follow ERA actually, but so many doctors follow that. So
No,
I
ma'am.
thought you.
No, there are complete evidence that ERA is outdated. We should not follow ERA. Ma'am, natural cycle is better. Modified natural cycle is better than ERA. I have made my PhD into this, and I have done what I do that before day of embryo transfer, I just check the progesterone. If it is more than 10, I
Yeah.
just transfer. Then it is okay. If the embryo is good, your lining is good, progesterone is more than 10, the patient will get pregnant.
So you you freeze embryos in previous cycles and then you wait for the natural cycle
Yes,
to transfer
yes.
those embryo?
Yes,
Okay.
yes. If we find there's some problem like in some lining is not ready, if we find fluid over there or the
OHSS
estrogen
or
level or progesterone level is changing, then we freeze the embryos. We don't transfer.
okay. For OHSS also you freeze the embryos and then
Yeah,
transfer in the next.
yes. Next in the next cycle,
Okay.
yes.
Okay then. Okay, I have more questions actually to clear it up and some suggestions also, but I think we will discuss personally so that
Yes.
other doctors should not waste their time. So I will discuss you personally afterwards. Okay. Thanks for your attention.
Yes, ma'am. You're always welcome. It's nice talking to you. Nice. Very nice, ma'am.
Thank you so much, ma'am. The next question, I think it is the last question. For FET natural cycle with modification, please elaborate.
Yes. We do the ovulation study of the patient. We just induce the ovary with simple letrozole. 10 days letrozole, either 1 or 2 gonadotrophin if we need. When we find that the follicle size is 18, and when we find that it is ready, then we give the trigger. And after 40 hours, we consider that this is the day of pickup, and then we calculate. Embryos are already with us. We do the that consider. We don't do the pickup, but we consider that pickup is done. On that day, we start progesterone, and then for 5 days for the progesterone and P+6, we just transfer the embryo, and we are getting really very good results. The modified natural cycle.
Okay. Thank you so much. Thank you so much, ma'am, for this wonderful and very informative and resolving our all the queries. Thank you so much. So
Thank you so much for giving me time.
yes. So on behalf of NIMA OBGY Central and NIMA OBGY Society, Maharashtra body, I would like to express my gratitude to NIMA Central, all the dignitaries of NIMA Central. Then I extend my gratitude to our NIMA OBGY Central President Dr. Kamini Diban ma'am, Secretary Dr. Priyanka Nakde ma'am, Treasurer Dr. Vishnu Bhavne sir, and Convener Dr. Rajesh Utne sir for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Meenu Bhanot ma'am, who took time
Thank you
from
so
her
much.
busy schedule and deliver a very knowledgeable and wonderful session. I would further like to extend my gratitude to all the dignitaries of our NIMA OBGY Maharashtra Society. Then I would also like to extend my thank to Dr. Girish DAGA sir and Dr. Arpita Shah ma'am for the help and technical support. Last but not the least, I would like to thank from bottom of my heart to all the delegates for their participation and presence. Without them, this webinar would not have been possible and succeeded. Now, with due permission to all the dignitaries, I am concluding today's webinar. And thank you also Dr. Aarti ma'am, Dr. Prajakta ma'am for coordinating today's webinar. Thank you all for attending and hope you have learned and gained great knowledge from today's webinar. Thank you so much.
Thank you, ma'am. Thank you so much.
Should I end the meeting?
Yes.